I just wanted to echo what Elliot said, and I'm really thrilled to be here, and I'm honored to have a chance to meet people. It's one thing when we're in the office and we deal with you guys on that level. It's another to have a chance to see you guys sort of amongst your own element and share your stories, because as you can imagine, we certainly care about a lot of things that happen, but as physicians, we're often like horses with blinders, and we tend to focus on very specific things. So it's nice. It's really refreshing for us to get a chance to step out of that. So this being a fireside chat, and I'm a very visual learner, I was expecting an actual roaring fire, some marshmallows, some comfy chairs. I'm sorry. So I will tell you right now, I thought the best thing was not to have really a didactic presentation. I'm just going to put up one slide, courtesy of Magnus, because my part in this is to discuss the treatment of PBC itself. And I think you guys probably know as much, if not more, than most of us when it comes to treating this disease. So, for example, hands up if you're on URSO. Pretty much what I expected. Hands up if you're on OCA. Okay, hands up if you're on nothing at all. Okay, so as expected, nearly all of you are on one form of medication or another. Oh, do I use this?
Go back to the table.
This one? Sorry. So I'm just going to keep that up there. I think for the most part, you guys understand how we approach things, which is which drug we try first, when we consider adding additional therapy. I'm not going to get into the specifics of the algorithms from our standpoint, although I can certainly answer questions. I just wanted to take a few minutes to discuss sort of how I deal with it when I'm in the office. So most of you are on URSO, and as you know, it's still our first-line therapy. When it works well. It's who here's seen the movie Anchorman? Okay, that joke's gonna fall flat, so I won't. Never mind. Never mind that joke. Anyway, the point is, as you know, though, although URSO is a quite safe drug, it's not effective in enough people. I mean, that's why there was need for additional therapy, which unfortunately took a very, very long time, but now we're grateful that it's happened and more is coming. So what I tell people in my office when they first get diagnosed is I try and give them a little bit of a lay explanation of what PBC is, and I sort of focus on the fact that they're producing abnormal bile, which can lead to inflammation, and also the fact that the abnormal bile, for two reasons, right? Because the bile being abnormal, the immune system thinks it's foreign, right? So it wants to attack it. And these abnormal bile itself doesn't tend to flow as well as normal bile, and bile is toxic, so that also leads to inflammation. And I try to explain the purpose of the URSO, and I tell a lot of my patients, which, because of where I work on Vancouver Island, I have a very high proportion of First Nations patients, and I tell them, this is the closest you're going to get to traditional medicine with a Western doctor. I'm going to give you bear bile. And then I reassure them that no bears were harmed in the making of this pill. But I do explain, I go, look, it's a synthetic bile, but it's the quote-unquote most normal form that your immune system that will not recognize as foreign, that will sort of dilute out the abnormal forms you're making, and as a result, improves flow of bile through your bile ducts, helps quiet down your immune system, therefore helps minimize further progression of the condition. And that's really it. And the reason I do that is because for many people, yes, there are symptoms with fatigue and pruritus, but we also know that can also be a bit separate from the disease itself, right? We put you on URSO, those symptoms don't necessarily go away. And I know that if I was a patient and I'm told I have a disease for which I don't have symptoms, because many people don't have any symptoms, and I need to take this drug that's not cheap for the rest of my life, I'd be raising my eyebrow. So I think it's useful to try and provide at least a basic mechanistic explanation so that they can sort of help be on board with why we need to do this, because granted, more and more patients are empowered, especially in BC now, they have access to their own labs. I can't speak to what it's like in other provinces, so they can look up their own labs, and often they call me and they're like, hey, is this working? Or, they like to check in, so that's fine. But others are still very more, okay, well, let me just see what the doctor tells me, and I'll take it from there, and that's totally fine. The point I'm just trying to make with that is it's nice, I think, to have some context rather than just be told, you have this relatively rare disease, you don't feel anything, you have to trust me that you have it. Oh, and by the way, here's a medication that's going to cost you or your insurance company a not insignificant sum. I mean, it's not among the most expensive drugs in the world, but it's not aspirin. It's costly. And what I tell people always is, we're going to try the medication for at least 6 months, assuming you don't have any side effects. I usually quote common side effects like some people get upset, in my experience, upset stomach, rash, hair thinning, for example. But I also tell people that most of my patients sail through without any issues whatsoever. And I go, look, we're going to do blood tests at 3 months. This is what I do personally. I don't necessarily say everyone has to do this, but I say we do blood tests at 3 and 6 months. I bring you back at 3 months, not so much to see if the disease has been responding to the drug, just to see how the patient's doing, just to touch base, go, look, are you doing okay? Do you have any side effects to this that you're really upset about or that's really impacting your day-to-day life? And then I bring them back another 3 months later to see, then that's the checkpoint to go, let's see if the condition has responded appropriately. And then we use that to decide whether or not we have to consider adding OCA, which, and I imagine it's fairly similar in other provinces, we have to go through a bit of hoops with the provincial government in order to get it approved because it's extremely expensive. And this actually, ironically, BC is a model for, if you want to make anything worse, make it go through the government. It was much easier when the drug was available only nationally and not provincially. I could just go through the program Navigate. They were great. It was efficient. It was fast. Now there's an extra layer with PharmaCare, and it's not just because I have to sit at my desk and fill out some paperwork and send it off. I mean, I don't like doing that, but that's not the issue. It's actually their response to me and then communicating with Navigate. And I was just discussing with a specific case where I have a rather sick patient who needs this medication, is completely the appropriate candidate and still hasn't been on it for reasons that none of us can quite understand why the patient hasn't received it yet. So I don't go into the mechanistics of OCA with my patients because it's a much more complicated process. It's not as easy to explain in lay terms, and I just don't see that there's a huge benefit unless people really want to learn about it, in which case, sure, I'm happy to do that. So, and then after that, some patients ask me, well, what if this doesn't work? And I'm not going to go into Alia's part here, but I explain to them, look, there are other drugs potentially on the way, and if you don't tolerate one or the other, or they're not working, we can then at least look into whether or not there's a clinical trial available locally. Unlike most of the doctors you're hearing from at this panel, I work in a small community center. I am affiliated with UBC, but I'm not at UBC. And so I don't have the benefit of performing clinical trials myself. I'm trying to piggyback onto what my colleagues do in Vancouver to act as a satellite, but that is not something that I can do yet. So I'm at the mercy of trying to see if what my colleagues elsewhere, South Island of me in Victoria or in Vancouver, are able to offer. But I always phrase it that way, as just to make sure that the patients realize, look, the first-line drug generally works well, even though it doesn't work in everybody. But if that doesn't work, there is a backup, which has been proven to be quite effective. And if neither of those seem to work for you, there's more down the pipeline. And even if we can't get you into a trial, fortunately for most people, I know this doesn't apply to everybody, so I'm not trying to diminish any individuals, it's a reasonably slow developing condition. It's not like autoimmune hepatitis where things can change very rapidly. And soon enough, we will be able to provide more options. So I think I heard it said by a few people today that this is a fairly exciting time for PBC as a physician. And exciting might not be the right word for a patient, because I don't know if you ever consider it exciting, but it's a fortunate time compared to, and again, I don't want to out who refers to themselves as the old PBC patients, but for those of you who do fit under that category, you know what it was like just a few years ago, or 10 years ago, or 15 years ago, and it's changed drastically.